Mhm. Good evening, everyone. Good evening. Welcome. Apologies for the late start. It was a bit of technical internet connection difficulties. You're most welcome. Good evening, Dr. Oiwal. Good evening, Dr. Gold-Olufadi. You're most welcome, everyone, to another session of the virtual skin NTDs training that we're having for health workers, which is facilitated by the Nigerian Association of Dermatologists and is sponsored by the International League of Dermatological Societies and the International Foundation of Dermatology. Thank you for joining. We have had a lot of people signing in for this webinar. We hope a lot more will join us today. Without wasting too much time, I'd just like to introduce our speaker for today. Our speaker for today is none other than our favorite dermatologist, Dr. Shakirat Gold-Olufadi, who is a consultant physician and genitourinary specialist who works at the University College Hospital, Ibadan. And she's going to be talking about scabies today. Scabies is very much the most common skin NTD that we see in Nigeria. It's very, very common, and unfortunately, it often goes undiagnosed, and people suffer a lot for many years. And because it's so infectious, the whole family is itching, and it affects greatly their quality of life. And it's unfortunate because it's something that is very easily treatable. So we want people to know how to recognize, diagnose, and treat scabies. And we're going to be talking about some of the factors that lead to. Can you hear me very well? Hello?
Yes, you're
Dr.
loud and clear.
I can, okay. Dr. Oiwa, good evening.
Good evening.
Good evening.
Is her voice loud or is it just me?
No, she's loud and clear.
What did you say?
She's loud and clear.
Loud and clear. Maybe it's the audio from your end, dear. So just try and
I don't know what's
see
happening.
if you're not
Okay.
hearing very clearly.
I'll try again. Don't worry. Let me just keep on.
Okay.
Just continue.
All right. So we want everyone to know how to recognize and diagnose scabies, because a lot of times we see people come to the clinic, they've had this itching for 1-2 years, and you can imagine the quality of their life for 1 year, itching, scratching, not sleeping well at night. And they've been to several clinics, pharmacies, given all sorts of creams and medications, and nobody has been able to diagnose them with scabies. So this is a very, very important webinar to attend, so that we can learn about scabies and how to recognize it and how to treat it. And then on the public health aspect, the fact that it's one of the NTDs, what we can do if there is a high prevalence of scabies in a community, there may be that community may qualify for mass drug treatment. So we're going to discuss all these, and so let me just welcome Dr. Gold to take over and start her lecture. You're most welcome.
Thank you very much, Dr. Cole. I don't know whether I should start now. Please, Dr. Cole, can you let me know if you can hear me loud and clear?
Yes, we can hear you very well. Very, very well.
Okay, great. Anyway, as long as you can hear me, I think that's what matters. So I'm looking at the number of participants that we have. And since we know that scabies is one of the NTDs that we really want people to know about all that.
Yes, so we can
Should we just wait a little? Because it's not going to take too long. So I suggest that maybe we take some time. Perhaps if anybody has any pending questions from the former sessions.
From former sessions, So yes, that's fine. We've spoken a lot
Let me
about.
just retweet it online now for people to join
All
and
right,
talk about it on.
that's fine. That's fine. So we have had a few sessions. Last week we spoke about leprosy. Um, Leprosy is still with us, even though it's not as common, but we still do see very bad cases of leprosy. Even after that webinar, there was a very terrible case of leprosy that we had, who had severe deformities and required amputation. And I was really sad because really that's what we do not want to see. We don't want to see people coming in with very severe forms of leprosy. We want to be able to catch it early. So if you missed the presentation on leprosy, I would advise that you go back to the YouTube channel and try to, go over that lecture. You can also visit the WHO, Open WHO website for, their own lectures on leprosy. Try to familiarize yourselves, particularly people who work in the community at the grassroots level. So in primary health care facilities, general hospitals, community pharmacies, community health workers, please familiarize yourselves with these NTDs so that when they come, we can intervene at an early stage. It's very important that early on these NTDs are recognized, diagnosed, and treated before they cause very debilitating complications, like the amputation of the unfortunate case of leprosy that I saw during the last 2 weeks, and another case of leprosy that, a young lady who of marriageable age, had already developed madarosis, that's the learning fishes of the face, and it really affected her self-esteem and self-confidence. And, that also went undiagnosed for a very long time. So those are the things we want to prevent by having this webinar series, the late presentation of these NTDs that really affect the lives and the livelihoods of the people who are affected. So please, you can go to the YouTube channel if you missed the webinars or you just want to go over it and revise your knowledge on some of these things. That resource will always be available on YouTube, and you can go back to it for reference. And also remember the WHO, Open WHO website for lectures on the various NTDs. So that also has non-skin NTDs as well as skin NTDs. Thank you. So I think we have about 40 people. We hope more people will join us as the time goes by. Okay. I don't know if anyone here has any questions, clarifications from previous webinars. If you do, I see Salisu Ahmad. Would you like to put your question in the Q&A, or would you like to speak? Okay, someone is asking, what is the YouTube handle? Okay, I will type it in the box here, the YouTube handle, so you can always go to that and look go through the previous lectures. Okay, I'll put it there now. Okay, so Dr. Gold, are you ready for us? Do we wait a bit more and or do we start? MCP 5157.
Dr. Cole, do you want me to start? Should I start?
Yes, I think we can go ahead now.
Okay, great. Thank you very much, Dr. Cole. Thank you. Once again, let me see whether I can share my screen. Okay. Can you see my screen?
Yeah, it's coming up. Yes, we can see it
Okay.
now.
Great, fantastic. So once again, I'd like to welcome us to this neglected tropical diseases training, and one of the many sessions that we've been having. First, I'd like to say a big thank you to Dr. Cole. Many of you may not know, but she's on maternity leave right now. And doing this while on maternity leave is no small feat. So I'd like to just take a moment to just appreciate Dr. Cole, because she's the engine behind this thing running. So I'd like to say a big thank you to her. And again, I'd like to say thank you to the International League of Dermatological Society, the International Federation of Dermatology, and of course, our Nigerian body, the Nigerian Association of Dermatologists, for all the support they've given us for this training. So my name is Shakirat Gold-Olufadi. I'm a consultant dermatologist at the University College Hospital in Ibadan. And today we're going to be talking about scabies. So the reason why I was asking us to hold on initially is because of how important scabies is. It's such an important topic to talk about that we cannot gloss over it. And we must make sure that as much as possible, we have a lot of people to benefit from this particular lecture. But, you know, maybe they will meet us along the course of the training. So let's just start. I'll be using this outline to talk about scabies, a bit on the introduction. We'll talk about the epidemiology, the life cycle and transmission, the clinical features, the investigations that you need to do, the management, and where we are generally, and we conclude the topic. So by way of introduction, that is the scabies mite right there on the left. So scabies is a parasitic infestation, and it's caused by Sarcoptes scabiei var hominis. So there are different species of Sarcoptes scabiei, but the one that causes scabies in humans, the clinical presentation of scabies, is Sarcoptes scabiei var hominis. And the reason why this is important to mention that the one that causes scabies in humans is because there are some mites, scabies mites, that can infest dogs, cats, cattle, and they can also find their way onto to human skin. These ones are not capable of causing the type of infection or the type of infestation that scabies will cause, because they cannot survive on the human body for long. So the one that causes the clinical infection or the clinical presentation that is called scabies in humans is called Sarcoptes scabiei var hominis. It is something that occurs worldwide. And the reason why scabies occurs worldwide is because all you need is human-to-human transmission. So it is no respecter of whether you are in Lekki, in the high socioeconomic class, you live in Ikoyi. All you require is human-to-human transmission. And I'm going to highlight a case for you to understand how important it is to have scabies as a differential when you see something remotely related to it, even if you are treating somebody of a high socioeconomic class. It is, however, more common in tropical countries and high population density areas, because the weather, again, kind of helps. It is not associated with mortality, but I tell you, if you have ever had scabies before, you will know that it's associated with a lot of morbidity. Imagine being in a meeting and you are trying to hold that itch, you are trying to scratch, because the itch that scabies can cause can almost drive you insane. It may run a recurrent course, and that's the reason why even in some old texts, you see scabies referred to as that condition that causes the 7-year itch. Because all you need to do is to propagate scabies is to have the adult mite on your skin. When you have the adult mite on your skin, when it lays eggs, another male mite comes and impregnates another female mite, because it's the female mite on the skin that keeps laying the eggs and all that propagates the infestation. So all you need is for that mite to be present and for you to, because the adult female mite lives on the skin. So it may run a recurrent course and cause significant morbidity. By way of epidemiology, the prevalence is estimated to be about 200 million worldwide. And the prevalence ranges, especially in temperate areas, from 0.2%, very, very low, to the tropical areas where it is really common. And in some reports, you can have it as high as 71%. However, it must be noted that those prevalence, it varies from region to region and from location to location. So in Nigeria, we have some prevalence studies that have been done. Onchocerciasis et al. In South East Nigeria. So there were about 3 or 4 hospitals that 4 hospitals over a 5-year period. They recorded an incidence rise from 0.18% to 6.67% over a 5-year period. The prevalence in Nigeria itself actually ranges between 4.7 to 25%. And unfortunately, young children and elderly are particularly vulnerable. Young children, because young children will play. And if they are carrying the mites, all they need, and remember that I said, all you need is human-to-human transmission. In resource-poor areas, up to 10% of children may be affected at a particular time. So this infestation actually poses a significant public health problem. I present this table. I want you to look at this table. There was a study that was done in Nasarawa, and this table was brought from that study. If you look at it in this table, the age group that was most affected, okay, so what they did was that they did like a door-to-door study of the prevalence of scabies in that particular area. And they went, they had some particular inclusion criteria, some baseline definition of what scabies is supposed to be. And they went door to door to do this examination. And so based on what I was saying, remember what I said, the age group of between 11 to 15 was most affected. And they had about 79.7% of them affected with scabies. Males were more affected than females in the study. And what you'll notice is that illiteracy, so not being literate, was a major risk factor, because out of the people that were affected, up to 310 of them were not literate. Again, what you'll see again is that unemployment was like a significant risk factor, because if you look at it, 304 of them were unemployed. Again, if you look at it again, monthly income, if you look at 18,000 as a monthly income, that is quite low. So monthly income of less than 18,000, 312 out of 424 had a monthly income of less than 18,000. So if you look at the factors that were significantly associated with scabies in that study that was done in Nasarawa, you will see that, and if we look at research, at least if we remember that when you have a p-value less than 0.05, I don't want to take us into confidence interval, because this is not a lecture on research. So this is a lecture on scabies. But if you remember, a p-value less than 0.05 for most studies, that at that p-value, most studies will say that that is significant. So if you look at this, 0.01, so age less than 10, and age less than, so let's say age less than 15 was a significant risk factor. Male gender was a significant risk factor. Illiteracy, unemployment, and a low socioeconomic status was a significant risk factor. And even number of people in a room. So once you have more than 4 people in a room, that was a significant risk factor. So I brought that study because there were not much studies done in Nigeria, but I found this study in Nasarawa very important to highlight. So again, if you look at the life cycle of scabies or of the mite itself, it goes through 4 stages. You have the egg stage, the larva stage, the nymph stage, and the adult stage. So what you have initially is that the adult eggs, the adult females, they will deposit eggs as the burrow on the skin, and they leave this burrow on the skin. Usually about, this burrow is on the skin, and that's like one of the hallmarks of scabies that you see on the skin, that burrow that the adult mite would leave on the skin. One thing you should know again is that the mite, it doesn't have the ability to go beyond the stratum corneum. Again, let me take you back to lectures on the skin. The skin has 4 major layers. On the palms and soles, the skin now has 5 layers. But the skin has 4 major layers. So from top to bottom, you have the stratum corneum, you have the stratum granulosum, the stratum spinosum, and the stratum basale. The basal layer, which is the stratum basale, is the one that regenerates the cells of the skin. And the stratum corneum, also known as the Herney layer, that's the layer that kind of sheds off. So the adult mite, the mite cannot burrow, and that's the reason why scabies most times, it cannot cause like a systemic infection. But after some time, you can have some complications that can now cause systemic issues. So the adult mite cannot burrow more than that stratum corneum where the pregnant mite will lay eggs. So look at it, that's the mite itself laying the eggs, and that's the burrow that is creating on the stratum corneum. This is the egg will hatch in 2 to 3 days, releasing the larva. The larva will molt into nymphs. When it molts into nymphs are found in those burrows called molting patches. Then you now have the adult mite. When the adult mite, mating would occur after the male penetrates. So that molting patch, the molting pouch of the adult female, the males will penetrate into that molting patch and they mate. It's interesting to note that after the male, and I'm sure you guys will say, won't males catch a break? Because when they mate with one adult female, that's almost like the end of their life, because afterwards they just die off. Okay, so human scabies mites, okay, they are often found, on the just think of the eating areas, the flexures on the fingers, in between the webs of the fingers, on the wrist, so all these areas that I've highlighted in red. And that's the reason why it can be so embarrassing. Okay, and you'll see as I go into the clinical features. So between the time the eggs are laid up to the time they hatch, till they become an adult, till they start to lay, they start to shed their skin and pass feces on the skin, because that itch that you see in scabies is actually more of the allergic reaction to the mite protein and feces. So the incubation period from the time the adult female mite starts to lay the eggs to the time when you start to itch, you need about 4 to 6 weeks. So that's why it is important to note this incubation period. That is why the risk of recurrence is very high. And you'll see that as I get to management. It is also interesting to note that most individuals at any time in their life, they are only infected with about 10 to 15 mites. So that itching is not because of the presence of the mites, it's more because of the allergic reaction to the mite protein and feces. And as I go on in the presentation, there's something we call Norwegian scabies. Norwegian scabies is like the worst form of scabies that you don't even want to wish on your enemy. By the time you see Norwegian scabies, you might not even recognize that it is scabies anymore, because these people, instead of being infested with 10 to 15 mites, they have millions of mites. They are teeming with mites on their skin. And people that would usually have that are the immunocompromised, people that, overcrowding, people that have HIV, people that are uncared for, homeless people are the people that would actually have Norwegian scabies. So like I said, by way of transmission, the incubation period is as long as 4 to 6 weeks. It requires human-to-human contact for transmission, where the adult mites, and the transmission is that the pregnant adult female mites, they are the ones that are transmitted. And that's the reason why, if you remember, I don't think there's anything that can be closer than sexual intercourse. So that's why scabies is frequently a form of sexually acquired infection in adults. We really don't like to call it sexually transmitted, but more like sexually acquired because of the close contact that is involved in sexual intercourse. It may also be found infrequently in cases of sexual abuse in children. So the reason why I put the word infrequently is that so that when you see a child with scabies, the first thing you think of should not be sexual abuse, except if you have reason to think of sexual abuse. Fomites, and by fomites, we mean your bedsheet, your pillowcase, your dresses, and all that. They are a less important mode of transmission. However, they are still important. The reason why they are a less important mode of transmission is because, remember, you require human-to-human contact. And the mites, when they are not on human skin, they actually die off after 72 hours. So if you have a person with scabies and you lock them up in a room, let's say, or you take all their clothing and your bedsheet and the bedsheet, you're not able to wash it. You lock it up in a room and you put it in a room, you don't wash it, they don't have any human contact with the bedsheet and all that, the mites will die off. They require human-to-human contact to be able to live. So they're actually very weak. So moving on, let's go to the clinical features. How can I minimize this thing so that I don't see this thing on my screen anymore? Because I can't see my screen. Okay, thank you. It causes the typical comobostop rash. It causes that typical, and when we say comobostop, I remember the time I had scabies in secondary school. Oh my God. And I did not even know what it was then. And used all the wrong things. They scrubbed us, we brushed, it was horrible. So it causes this typical bus stop rash, meaning you are at the bus stop, you are not even caring, and you are scratching away. And that itching is worse at night when the skin is warmer. So the reason why the itching is worse at night is because the skin is warmer and you are less busy at night. So you remember to scratch your skin. The commonly affected areas include the interdigital clefts, the fingers and the toes, the wrists, the upper limbs and lower limbs, the belt area, the intergluteal cleft, in between the buttocks, the antecubital fossa, the popliteal cleft. Popliteal cleft, the back of, for people that are not medical, that are not, just to describe properly, the back of the knees, the insides of the elbows, the in between the buttocks. In children, it is not uncommon to involve the face. When you have it as Norwegian scabies, it may be generalized and be crusted, and it would even look like chronic eczema in some cases. Remember that I said that it is more of something that causes significant morbidity rather than systemic symptoms. However, if you scratch the skin enough, the skin is a protective barrier. Once the skin breaks, it becomes easy for secondary bacterial infection to occur. So secondary bacterial infection may be a form of clinical presentation. It may present with complications such as glomerulonephritis and renal failure. And the renal failure, secondary to the glomerulonephritis and all. So this picture, these are the different phases of scabies. The typical rash. So this rash, this child, and if you look at this child is very interesting. Please give me 1 second. 1 second, please. 1 second. Sorry, I just have to sort a quick emergency. 1 second, please.
Okay, no problem. So yeah, these are some of the very common areas where people have scabies. Very, very common. In fact, in a lot of children, when they complain of the itching, you ask them, is it worse at night? And then you ask for the locations, the classical distribution of scabies, particularly, in the groin area, on the penile shafts in males, in between the fingers, the interdigital clefts, and, there are other people in the house who are also itching. We are almost certain that, that is scabies.
I'm so sorry. I had an emergency to sort out. I'm so sorry.
No problem. No problem.
Thank you
Go
very
ahead.
much. So as I was saying, should I continue, Dr. Cole?
Yes, please.
Okay. I don't know why. I just can't hear you, but I hope everybody can hear me. So as I was saying, this particular picture, this first child in this picture, this is one of my, they are all my patients in this picture. All these people are my patients. This picture is very, very significant because this child is the typical living in the highbrow area of Lekki, nannies, maids, everything. And she had this rash. She had seen a doctor. She had seen different doctors. They had biopsied her. Unfortunately, they didn't get the lesion of scabies in the skin. They had biopsied, had gone as far as biopsying. And by the time this child got to me, she had been dealing with this for about 4 or 5 months. So when she got to me, the first thing I saw, it's something that we see regularly. So the first thing I was like, oh, this is scabies. And the other doctor there was like, scabies, somebody living in Lekki. And I was like, this is the first, misinformation that a lot of people have. They think that people in the high socioeconomic status or living in the highbrow areas can't get scabies. So by the time I started my history taking, all you need is human-to-human contact. So after taking a history, I realized that she was with her grandmother and they went to, they were staying with the grandmother. I traced that history. I was able to trace it back. The grandmother was itching. Everybody was itching. And by this time, the nanny was itching. Everybody was scratching all over the place. And I don't know until she got to me before she got the diagnosis. So I treated this girl and she was supposed to come for a follow-up 2 weeks later. I've not seen her till today. And that's the reason why she's fine. She's totally fine. I treated her. I told her to come for a follow-up. I reached out to the parents and I reached out to the hospital where I saw her. And I was like, I've not seen this patient for follow-up. The medical director told me she's fine now. She doesn't need anything, so she's good. So that's the typical history. If this girl had not gotten somebody that had diagnosed it, I can assure you she would have been going around with these skin lesions for a long time. This second patient here, I brought this picture because this is one of the lesions that you would see with scabies. It can look like this, so scary, and you wonder what is wrong with the patient. Again, in this environment, a lot of people use triple action creams. The first thing people go for is triple action creams. So sometimes, steroids are in triple action creams. No matter what you are treating, anytime you use a steroid cream, steroids calm inflammation. So the itching of scabies might be so reduced that when you are seeing the patient, if you don't have a high index of suspicion, you may not be able to diagnose scabies in the patient. Unfortunately, steroid creams, when you are using them on an infection, you're going to propagate it even more. So you calm the inflammation, but the infection gets worse. So this patient, I treated this patient too, and it was fine. So these three pictures, they are for the first girl in the picture, and this is another patient entirely. So just to show you how scabies can look like, okay? Then I don't have a picture of Norwegian scabies, so I had to pick one from the internet, from Semantic Scholar. So if you look at this patient, it doesn't look like he has scabies, but this is how Norwegian scabies can look like. You would have these heaps of crusted skin teeming with mites. So this is how it will look like, as if the patient has chronic eczema. And if you are not patient enough to take a good history, you might miss the diagnosis of scabies in the patient. So how do you investigate a patient with scabies? Largely clinical. And by clinical, I mean the history and the physical examination. The burrows on the skin, you can see some of the parts of the adult mites. You can see some of it on the skin. And when you are examining it, it's good to examine with a hand lens, because you may be lucky, you may find the mites on the skin. And unfortunately, the mites tend to, if they are staying on the sheets, they tend to stay within the seam, so you might not find them easily. Another thing to do again is that you can do a skin scraping for microscopy, but that has to be done quickly. Excuse me, when you scrape the area where you have the burrows, you're not adding anything. You just take it under your microscope, you go and examine. You may be able to see the feces, the scale, the parts of the mites, parts of the mites on the microscope. You may even be lucky to find the adult mites, although I don't think they will wait for you. They would have just crawled off the skin. Another thing you can do is a skin biopsy for histology. Hardly would you need to do a skin biopsy for histology in scabies, but when you do it, you're going to see this intracorneal. And let me just take you through. Remember, I was telling you, this is the stratum corneum, this is the stratum granulosum, this is the stratum spinosum, this is the stratum basale, where you have the dermoepidermal junction. And here you have the dermis. Okay, so the stratum corneum, if you want to know how it looks like, is the one that lacks, it doesn't have any cells. The cells are not nucleated. So unlike other ones where you can see nuclei, the cells are not nucleated. So this histology picture was taken from one of my colleagues' papers that he submitted online in the International Journal of Dermatology and Venereology. So if you look at it, look at the parts of the mites enclosed, intracorneal scabies mites enclosed within the stratum corneum. So that's how scabies would look on histology. But generally, most times you don't need to do a histology to be able to diagnose scabies. So moving on to management, how then do you manage scabies? The most important thing is that you have to counsel the patient. You must counsel them that this condition is not because of anything you did wrong, or you have to counsel them properly. Again, you must treat all affected and unaffected close contacts. And by close contact, I mean that, for example, you are treating the husband, you must treat the wife. You are treating the children, you must treat the nannies in the house. But you don't need to treat the gate men if they don't live in the house. You don't need to treat, so if you have a security that comes into your house frequently, maybe he sits on then you might need to treat them. But if they are just your security and you don't have any contact with them, you don't need to treat them. So you treat all affected and unaffected close contact, and you must trace it back to the incubation period. So if you look at that child, I treated that child, I treated the grandmother and everybody living with the grandmother. I treated the father, the mother, the nannies, and everybody in the house. Okay, you must wash all beddings and clothes and underwear that the individual has been in contact with for 72 hours and below. So for 72 hours, 48 hours, 24 hours, anything higher than that, most times, especially after treatment, you don't need to do all that. So you wash all the beddings in hot water and you in the hot dryer. In this environment, if you don't have a washing machine, you wash, and after you wash, you dry in the sun, and then you iron. Use of scabicides. So the drug of choice, when you want to treat scabies, the drug of choice for treating scabies is actually 5% permethrin cream or ivermectin tablets. But I've come to realize in this environment, most times, especially if you have patients with Norwegian scabies, I use both the permethrin cream and the ivermectin tablets. But it's either you use 5% permethrin cream or ivermectin tablets. So if it's an adult you're treating, you are giving the permethrin tablets, 4 tablets, that's 12 milligrams. Okay? Other scabicides, because you won't say because permethrin is not available, then you won't treat the patient. Other scabicides that can be used include benzyl benzoate, which is the common one we all remember. But benzyl benzoate is highly irritating to the skin. So a lot of people don't tolerate it well. So sometimes if it's benzyl benzoate you have, you can dilute it a bit with water or even with some Vaseline. And then to use it, you apply whatever scabicide you are using, you are applying from the neck down overnight. If you are treating a child, remember I said the face can be affected. You apply on the face. Apply it from the neck down overnight. So let's say you are going to bed by 8 p.m. or 9 p.m. You can apply from like 7 p.m. and the next morning you wash it off. The face must be included in children. If it is benzyl benzoate, that's the common one you find around here. We prefer permethrin cream, but if it is benzyl benzoate, you are doing what I've just explained. You are doing it for 3 consecutive nights. So let's say you start the treatment on Sunday, you do Sunday, Monday, and Tuesday, and then you review the patient afterwards. You can reapply such again 3 consecutive days like that if there's no relief, let's say after 2 weeks. Because most of the time, if you remember, I mentioned that the itching of scabies is due to the allergic reaction to the presence of the mite, feces, and all the other things. So initially, when you first start treating scabies, the patient might even experience more itching when you first start treating scabies. So it is not because your treatment is not working, it's because of the allergic reaction itself. And so you need to counsel the patient and let them know about that. If it is permethrin cream you are using, you're going to apply from the neck down or from the face down overnight, and it is just a one-off application. You can repeat the application in 1 week afterwards, but it's just a one-off application. If you have, if you're using ivermectin tablets, please, pregnancy is a state where everybody is always cautious. So it's not recommended in pregnancy. So you do permethrin cream, the benzyl benzoate. And if you are treating unaffected contact, you can either use permethrin cream but most times we usually use ivermectin tablets in the unaffected close contact. And by unaffected, you mean they've not manifested, because some of them might be harboring the mites and they've not even just manifested. So ivermectin tablets usually not recommended in pregnancy or less than 15 kg. But to be honest, if that's all that is available, I never use it in pregnancy, but in children, I still use it cautiously in children sometimes. So remember what I said, itching may be worse initially after treatment. So you can give antihistamines while you are treating. Antihistamines, the non-sedating ones like loratadine, cetirizine, fexofenadine while you're treating. So again, remember that I mentioned complications. You can have secondary bacterial infections like impetigo. And from impetigo, remember that we can have glomerulonephritis when you have some skin infections like impetigo. So from glomerulonephritis, you can have renal failure. So those are the major systemic complications that you can have. But however, we cannot underestimate the significant negative impacts that scabies has on the quality of life. So it can have a significant impact on the quality of life, especially after you've gone to different doctors, different healthcare workers, and they've been unable to diagnose the skin condition that you have. So what is the way forward when we're talking about scabies? World Health Organization is working with member states, and partners to develop control strategies and scabies outbreak response. And when we talk about control strategies, even this lecture, even what we are doing is part of developing control strategies, because I know that after this lecture today, everybody will be able to diagnose scabies, okay? And at least you have a high index of suspicion. Then they are working on adding ivermectin to the essential medicines list. It's not to be used as a preventative treatment, but at least to make it readily available. If you remember during the COVID period, a lot of our patients who needed ivermectin for other things, they really suffered with the way people hoarded ivermectin during that period. And more efforts are in place to ensure that this medicine are affordable and available. So what are the differential diagnoses of scabies? And I forgot to put pictures. Why did I forget? Papula urticaria, what I would advise is, I don't know how I forgot, but papula urticaria, if you've ever seen papula urticaria before, you will see those children, they would look like as if they have dots on their legs, you know. And papula urticaria usually occurs because of hypersensitivity to insect bites. Some children are sensitive to the saliva of insects, to the bites of insects, that when the insect bites them, instead of reacting in one place, they have this generalized reaction on the exposed areas where the insect bites them, on the arms and the legs. So unlike scabies, where you have it in the webs of the fingers, the buttocks and all that, papula urticaria is a lesion that you'll see more on the legs and on the arms. And it is more of a condition that is common in childhood too. So if you have a child with papula urticaria, usually is to counsel them to wear more of protective clothing to ensure that they use insect repellent cream when they are going out with the children. Folliculitis, hardly would folliculitis be generalized, but if it becomes generalized, like if you have eosinophilic folliculitis, is also a differential of scabies, but it will not differentially affect the webs of the fingers and all that. Insect bites, again, not necessarily papula urticaria this time, just single insect bites causing itchy lesions on the skin. But you know, you have that history of insect bites and it won't affect the webs of the fingers and the toes. Lice infestation is another one that can really look like scabies. Luckily, the treatment is similar. And sometimes you're able to pick out the lice that is causing the infestation. There's something we call EAD reaction. EAD reaction is a hypersensitivity reaction, usually to the presence of a fungal infection on the skin. So let's say somebody has tinea. Usually it happens with fungal infections, but it can happen with other infections. So let's say somebody has a tinea manum on the hands, or let's say somebody has tinea corporis on the skin. You can see these rashes on the fingers and all that, or on the toes. It's a hypersensitivity reaction to the presence of the fungi. And what happens is that when you treat the fungal infection, the EAD reaction disappears, okay? So another thing is gyanotic crusty syndrome, which usually can occur after a vaccination. So somebody gets vaccinated, child gets vaccinated, can develop these itchy rashes on the legs and the arms. So those are differential diagnoses of scabies, just to mention a few, the common ones. So in conclusion, scabies is still largely a concern in developing countries and in the tropical region. And that is why we must ensure that we are attacking it vigorously, and we are ensuring that we are able to diagnose scabies, and at least, even if not manage, we're able to refer to a doctor that can manage. It causes significant morbidity and impacts the quality of life adversely. So it is important that it must be addressed. And why should it not be? It's something that can be treated. It's something that is curable. So we must make sure we address it. And one of the reasons for chronicity is excluding close contacts from treatment, and also thinking that people of the high socioeconomic class cannot get scabies. So thank you. These are my references, and thank you for listening.
Thank you so very much, Dr. Gold-Olufadi. That was a fantastic presentation on scabies. We are really, really grateful. And I know that most people now who have attended this webinar will not miss scabies. And that's very essential because, like we said, it does really affect the quality of life of a lot of people who have scabies. And the earlier they can have appropriate treatment and diagnosis and treatment, the better. And also, the earlier that patients are treated, the less likely they are to spread it to the environment. Most of our secondary school boarding houses in Nigeria have scabies outbreaks from time to time. And it's very challenging to manage because, it goes round and people go home and carry scabies home, and it's a problem. Another large reservoir community for scabies are the prisons. I go for prison medical outreaches quite frequently, and always it's always a challenge in the prisons, because of the close contact. Our prisons are overcrowded in Nigeria. You find out, there's almost 100% prevalence of scabies amongst the prisoners, particularly in the Ikoyi prison, where they are waiting trial and they're just jam-packed like sardines in the cells. So when those people in the prisons, are released and they go home, they take the scabies out into the community. So these are some reservoir area, and in areas where scabies is very highly prevalent, there can be, or there should be, the opportunity for mass drug administration, MDA. And I know that the WHO is looking into, recommending ivermectin for MDA for scabies, along with other NTDs like, Onchocerciasis and the like. So thank you so much, Dr. Gold-Olufadi. We have a few questions. I answered one or two, but I left one or two for you if you'd like to answer them live, and we can have an open discussion on scabies.
Thank you, Dr. Cole.
Love to have input also from our other facilitators, Dr. Oiwo and Dr. Abdullahi. Thank you.
Thank you so much, Dr. Cole. Thank you. And thank you, everybody, for listening. So I typed the answer for, will a patient be given ivermectin with the use of benzyl benzoate, or we use just the benzyl benzoate? So I would say, if ivermectin is available, it is either ivermectin or 5% permethrin cream. Those are the drug of choices for, that's the drug of choice for scabies. So if you are using if you have ivermectin available, you actually don't need to use the benzyl benzoate. So if I presume that you are probably using the benzyl benzoate because the ivermectin is not available. So once there is ivermectin available, then you don't need benzyl benzoate. Why are they immunocompromised? I mentioned that sometimes, especially when I have patients with Norwegian scabies, I use both the ivermectin. In fact, for Norwegian scabies, you need to retreat because they have millions of mites. Okay, and I forgot to mention that when you are managing a patient with Norwegian scabies, they are very, very infectious. So the less contact they have with people, the better. Even with the healthcare workers that are managing them, the less contact, the better. Immunocompromised, why are they at great risk of Norwegian scabies? And why do steroids also have an impact on parasitic infection? So it's the same reason why immunocompromised, people that have psychiatric issues, people that, number one, is because for the immunocompromised and the steroid users, most of the time, they are not able to mount an adequate immune response to the presence of the mite itself. So they might not even itch initially. So the mites just keeps getting more. And most people that use steroid, the same thing, because of the immune suppression that they have. That's the reason. Then, so the steroids having an impact on the infection is more of because of the immune suppression rather than anything else. So I've answered the question. I presume that the anonymous attendee is asking the same question. I was contacted by a fellow junior colleague. Of course, doctors are not immune to scabies. And in fact, doctors can get scabies from the health workers. However, I think that if you practice universal safety precautions, you wear gloves, you do all you're supposed to do, you're not likely to have gotten it from the patient. You may have gotten it even from your own house or from another place that you visited. So if I were treating the doctor, I would like to take a history, at least to go back into the patient's life to be able to ensure that I'm not missing out anything. Is there any standard laboratory where these NTDs can be diagnosed? So usually, if it's for scabies, you don't really need any standard laboratory per se. But usually for most teaching hospitals, they have the labs that are attached to them. But let's just say that labs for NTDs, and that's one of the things that we are really lacking in this environment, the supportive structures, the laboratories that we need to do all these diagnoses. And we all know some of the peculiarities of our environment and all that, but majority of the teaching hospitals, the federal medical centers and all that have all this laboratory support. What is the benefit of using both oral and topical? You know, we live in Nigeria where if patients have something on their skin, they don't believe you've treated them if they've now applied something on it. That's so there's no, you can treat with either topical or oral. But if you have those patients that, and because I am one of those doctors that believe so much in the psyche of my patients. If the patient tells you that, oh, I can never get better if you don't give me any cream to apply. So this kind of patients, you can combine, especially when they have a high mite infestation. Maybe they are moving towards Norwegian scabies. You can use the two. But treating scabies per se, you don't need to use both oral and topical. Using oral alone in form of ivermectin, or using topical alone if you have the drug of choice in form of 5% permethrin cream is enough. It's fine. Okay. I think I've answered most of the questions. I'm not sure I've left anything out. Is there any second line agents? Yeah, I talked about hardly would 5% permethrin fail. If you use 5% permethrin properly, the way you're supposed to use it, and you are sure you are dealing with scabies, it's not likely that. So again, remember that you must consider differential diagnosis when you are treating properly and you are not getting the right results, okay? Especially when you are treating somebody that you think is scabies and they don't have any history of any other person itching around them. You must consider other differentials, okay? Thank you for this. What about malathion as one of the modalities? It's part of it. They are all scabicides, but it's down there on the list. So I would rather have use benzyl benzoate rather than malathion. Okay, I would rather use 5% permethrin cream rather than malathion, especially if it's and 5% permethrin cream, or like before, is now available. Anyway, I practice in Ibadan, so we have it available. It's available in Lagos, but I can't say about other areas. So if you don't have permethrin cream, please use benzyl benzoate. And if you think that with benzyl benzoate alone, because it's highly irritating. If you have someone using benzyl benzoate, they will tell you it stings, it hurts the skin. If you've ever used it, but that was what they used in treating skin. I've still not forgiven that person that they gave me benzyl benzoate then. As dermatologists, do you touch these patients with bare hands? There's no reason why you should be touching your patients with bare hands. Sometimes, if I'm dealing with the condition, and please, I don't want you to do that. Do not touch patients with bare hands. Always observe universal safety precautions. But people that stay, my house officers in the clinic, I do that sometimes, especially when you have a patient with a condition that has been so stigmatized. You have a patient coming to the clinic telling you that even my spouse does not touch me. And they are so sad. They have this look, sometimes. So let's say I'm managing a patient with, let me say lichen planus, for example, and I know it is lichen planus. Or I'm managing a patient with atopic dermatitis, adult atopic dermatitis, and I know it is atopic dermatitis. So I'm not saying you should touch your patient without gloves. So I will tell my doctors that please wear gloves, but I will touch the patient, hold the patient, and tell them that you can see that I am holding you. Your condition is not something that anybody should stigmatize you for.
Yes,
your condition is not
vitiligo.
Contagious. Yes, even vitiligo.
Yes,
I run my hands on their arms.
Yes,
so I do. Dr. Cole, so you do that a lot too.
Yes. Because they feel people always stigmatize. I said it's not contagious. And I had a patient who told me, I'm so happy, doctor, that you touched me. Because everybody runs away
exactly.
from
Exactly. I have patients telling you. Yeah. Please, Dr. Cole, continue. Please continue.
So as form of psychotherapy for our patients, there are some patients that this is not an infectious problem. And just to reassure them, assure them and allay their fears, you may want to touch them physically. But if you do know that this condition is infectious, please, or if you're not sure, please observe universal precautions by using gloves, hand hygiene, and the like for patients. I also want to say that for scabies, a lot of times, if you only treat the patient and you don't treat household contact, they are going to have a recurrence, and then you feel like the treatment hasn't worked. The treatment worked, but because there's still a reservoir in the house, even amongst those who have not yet manifested the symptoms. For instance, the person may be the only one itching at that time, but others may be in the incubation period. So if you only treat that patient, you will find that, within a month, they're coming back with a recurrence or less. So it's very important in scabies to treat household contact, to treat close contact. If they're in school, you need to inform the school or health authorities that there is scabies amongst the students, so that all the students, particularly in boarding school, can be treated, or in a creche, or in a classroom. Children play, they hold each other, they touch each other. So if you do treat only with one person, and you're not treating their close contacts, you're not going to achieve complete resolution. And I've had patients like that with recurrence of scabies because they did not, other people in the household did not take treatment. So that's very essential with scabies. You must treat close contacts.
Thank you, Dr. Cole, for this important contribution. And again, just to piggyback on what Dr. Cole just mentioned, I've had cases where I had to treat the whole boarding school. Like I had to treat, because they had an outbreak, I had to treat like the whole hostel, people living in that hostel. So I had to ask, and I told the school principal to come. I had to have like a talk with them so that they could treat the whole school, especially in that class. They had an outbreak then. So I mentioned it again, that areas where they are overcrowding, camps, it's not uncommon. You come back from Redemption Camp, you come back from NASFAT, IVC, you come back from boarding school. So those are the typical things that you get anywhere where you have overcrowding. And you must remember to treat almost everybody, or everybody that has been exposed or close contact. Okay. Can you use diethylcarbamazine? So please, Dr. Adiza Mohammed, please don't touch patients with your bare hands, because as dermatologists, and that's why people say we are using voodoo. All I have to do is just see somebody and I know what I'm saying already for most of my patients, but you may not know. So I really wouldn't want you touching patients with your bare hands. So please don't touch patients with your bare hands. Can you use diethylcarbamazine if ivermectin is not available? No, it's not one of the drugs used in treating scabies. Yeah, well, that's for lower. So we are talking about that's for filarial worms. As a child, our aunt brought home from a boarding school following a water shortage. They closed down the school and it spread to all of us. Is it closing down the school? No. So the ideal approach is to have gone to the school, exactly what I did for the other schools, had a talk with the principal, the head of the school, counsel, in fact, talk to them at the assembly. Then you treat everybody. You give them a dose of ivermectin. And just a jocular thing about when I got scabies too. When I got scabies in secondary school, I brought it back home. I gave my mom, my siblings, everybody in the house. So it was something, what they call carry lay. I gave it to everybody in the house. So that's the usual history. So you don't close down the school, you treat everybody. You do a mass, and that's what we call the mass treatment with ivermectin. What is the dose of ivermectin for a 14-year-old? I'm going to have to check that, but it's dependent on the weight. If that 14-year-old is already adult weight, and while I'm talking now, let me just check it. If that 14-year-old is already adult weight, you give 12 milligram, okay? So if the 12-year-old is already adult, the weight of an adult, let's say like 40, 50 kg, you give the adult weight. So if it is, somebody is between 15 to 24 kg, you are giving 3 milligram. Each tablet of ivermectin comes in 3 milligram. So if the person is between 15 to 24, 3 milligram, that's one tablet once. If the person comes 25 to 35, 6 milligram, 36 to 50, 9 milligram, 51 to 65, 36 to 50, I beg your pardon, 9 milligram, 51 to 65, 12 milligram. What is the role of dermoscopy? Oh, fantastic. Dermoscopy is quite, if you have a dermoscope, fantastic. I didn't mention the dermoscope.
See the mites, yeah.
Yes. You would see the mites on the skin. So the dermoscope is almost like a microscope. It's like a handheld microscope. So you just put it on the skin and you look at the mites on the skin. So again, the dosing of ivermectin, I've mentioned it. If it is pediatric, remember it's still the same 15 to something milligram that I mentioned.
Yes. Here. Usually they calculate, I think it's 200 to 300 micrograms per
kg. Yes.
Yes.
200
so
to 300
if you can
micrograms.
calculate if you know the weight, you can actually calculate how much of ivermectin. Each tablet is 3 milligrams.
3
Some
milligrams.
people say
For me,
0 and 7 days. Other people say give 3 doses, 0, 5, and 14 days. 0 at day 0, 5, and 14. But 2 doses, is sufficient. And some people just give a start dose. But 2 doses at 0 and 7 days. or just a start dose is
A
sufficient.
start dose.
Yeah.
Usually, I'm so
I'm sure
sorry.
those are your boys.
Usually one dose is enough. But if the
Yes.
patient, and remember that I said the hypersensitivity is what to the feces, to the mite itself, is what causes the itching. But if the patient is still significantly, having a lot of itching after 1 week, you can give another dose in 1 week. So usually, most times, I just do the start dose and repeat that same dose in 1 week. Start and repeat in 1 week. Start and repeat. But for Norwegian scabies, you might need to do day 0, day 7, day 14. And by Norwegian scabies, please don't be the one treating. Just refer the patient, especially if you have access to a dermatologist.
Handled by a specialist.
Yes. So for the dosing of drugs, when I'm giving most of my lectures, it is the least thing. I hardly would I put it in the lectures because you would forget, number one. And I always prefer that when you want to give the drug, you check. When you check so that you are sure that you are giving the correct dose. So another question has come up on the dosing, and we've answered that already. I have a patient with generalized body itching, rashes, occasional foot swelling, redness of the eyes. She has used ivermectin. I thought maybe she has onchocerciasis, though she's not resident near fast-flowing water. Where can she get a definitive diagnosis? To be honest with you, this is not enough for me to make a diagnosis for this patient. So I really cannot say. So this kind of patient, I would suggest they book an appointment with a dermatologist. You can refer them to a dermatologist because there are some things we might see that you may not see, and we'll be able to make the diagnosis for the patient. Differential diagnosis of Norwegian scabies. The first differential is anything that can cause chronic eczema. So atopic dermatitis is a very good differential for Norwegian scabies. Atopic dermatitis, even patients with psoriasis, but just that psoriasis is not typically itchy, okay? So atopic dermatitis, anything that can cause eczema on the skin. And remember that I mentioned before that eczema is not what people call eczema. Most people outside call pityriasis vesicular eczema. Eczema, we talk about eczema as a skin that is irritated. And when it is chronically irritated, you can have this scaling and this thickness, lichenification that we call thickness, lichenification, which we will see as scaling as thickness on the skin. What is the dilution ratio for benzyl benzoate? So it's not exactly like a dilution ratio per se. It's because of the irritation. So it's something that you can do like a 1-in-1 dilution. You can just to reduce the way it stings on the skin. And even with diluting it with water, a bit of water, even with Vaseline, it still stings a lot. So it's definitely not our first choice when you want to treat scabies. But please, if that is all that is available, use it. If that is all that is available. Please, Ma, when sharing the slides with us, we don't usually, it's the recording that you have. You don't have we don't share the slides per se. So what I would advise, so this is like homework. Homework number 1, all the differentials that I put there, just go on Google. Just say papilla urticaria in black skin. I can assure you, you'll see more pictures than I can ever give you. Papilla urticaria in black skin, folliculitis in black skin. Just do that. And that's how you'll be able to see a lot of the differentials that way. Okay, will the prophylaxis and treatment? Yes. So if you want to treat, I don't want us to use the word prophylaxis. I want us to use the word treatment rather than prophylaxis. So, because by prophylaxis, you mean that prevention. So, okay, yeah. So we can say prevention of have other people in the house or close contacts having scabies. So you can use 5% permethrin cream too for them. But usually we do ivermectin tablets for treating unaffected household or household contacts, close contacts that have not manifested the condition. Okay, we usually will do ivermectin, but you can do 5% permethrin too. Thank you for bringing up this question. How can you decontaminate household furniture? So the thing is, like I mentioned, most times the fomite transmission is not a very important mode of transmission because the mites actually would survive on the skin. If you leave them on the furniture, they would do the hidden seams, and when they are within the hidden seams, if they don't get on the human skin, they die off. So it's more important to decontaminate the beddings, the bed sheets, the clothing, and all that. All those spraying the house using insecticide, it doesn't do much for them. The most important thing is to wash the beddings, the clothes, like I've explained earlier. Okay. Thank you for the lectures. Does it mean I can't give ivermectin after using benzyl benzoate? No, I didn't say that. I said that you can give it if you're using benzyl benzoate. So it's not necessary to use both tablets and cream. That's what I want to reiterate in this lecture. It's not necessary to use both the tablets and cream. If you have used benzyl benzoate, you don't have to use especially if the patient has tolerated it, they've used it. The only thing I'll tell you is that most people don't use benzyl benzoate the proper way. You use it for 3 consecutive nights. So if you have used benzyl benzoate, you don't need to give the ivermectin again. Okay? Thank you. I think I've answered all the questions at this point. I've answered all the questions. I don't think I have any other question that is pending. And thank you so much for listening, everybody. Thank you.
Thank you, everyone.
Sorry, Dr. Cole.
Yes, Dr. Oyewo, yes, please. We wanted to discuss the role of in the NTD control program, because Dr. Nafisa, I was sharing with Dr. Oyewo that, you know, Dr. Abdullahi phoned and was like, oh, they're seeing an upsurge of scabies in the clinics, but the public health authorities, you know, were not sure if scabies was part of the NTD program as regards treatment. So I was discussing that with Dr. Oyewo earlier today, and, you know, he said, you know, I said, let's discuss it and see and know what to do. So if you are seeing an upsurge of scabies in your community, in your environment, will that community qualify for mass drug administration? Is the treatment of scabies free, as is the treatment for most NTDs? So those are some other questions and clarifications that we'd like to talk about. Over to you, Dr. Oyewo.
Okay, thank you very much, Dr. Cole, and I want to thank Dr. Gold for such a stimulating lectures filled with a lot of experiences and examples. I must say that scabies has been more or less, permit me to use this colloquial term, commonized as one of those things. So much so that even the policy makers do not seem to see reasons as to put funds, put efforts into eliminating scabies. And for those who had said that scabies is not on the NTD program for Nigeria, well, to some extent, they may be right, because if we look at the 2022 to 2027 strategic plan for NTD, it is stated that Nigeria is focusing on 13 out of 20 NTDs. And out of those 13, scabies doesn't appear to be there. And Dr. Gold has rightly said that scabies is the highest, you know, has the highest prevalence among the NTDs. And if we all Google, just type NTDs and Nigeria, if you look at all the works, you will find out that many of the works that have looked at NTDs generally have found scabies to rank first, if anything short of first, second. And so the question is, why our policymakers, and I believe we have some policymakers among us who can also help us push this, why are they shoving scabies aside as though it were not important? Possibly because it doesn't lead to death, in quotes. But we do not have to wait until a disease leads to death before we start putting funds into it. As Dr. Gold rightly said, yes, the fatal outcome of scabies is not much, but the non-fatal outcome, wherein comes the quality of life impairment, the man-hour loss, the functional state of the individual being affected for those few hours or days the person suffers from scabies, is far worse and is pretty comparable to some diseases with high prevalence. So it's an appeal to our policymakers who are here to tend to pay more attention to scabies. Now that we also have a high incidence of skin bleaching all around the whole place, so that also would cause some more increase in the incidence of scabies. And for those of us who are dermatologists, we've seen quite a number of patients coming with repeated, you treat them, they come in after a few weeks or months with the same thing. And when you probe, you will find out that this person has been using this same cream, no contact and all of that. So we need to also look into that aspect. And it's also good to know, of course, on a lighter term, for those of us who are in the South-South, Dr. Gold said it's called Mobostop in Southwest. I think it is South-South. We call it Sweetie, Cro. So it's good to also know some of these words, because some patients may not be able to describe some of these things until they use those words. And it's important to know that casual contact does not lead one to contract to get infested with scabies. Some sources have said that contact of between 15 to 20 minutes, prolonged contact, are those needed. And that is where that supports some reasons why dermatologists would, yes, part of the psychotherapy is to touch the patient. But of course, if you do know this patient is contact spread, then you take the necessary precautions. And it's also important to know that, you see, for all these, in quote, severe symptoms we have, we do not have more than maybe 12 to 15 mites on the entire body to cause all of these problems. While for those who have immunosuppression, in what we call Norwegian scabies, have been said, we can have up to 1,000. And that is why you have the lesion very florid in them. And another important thing for us to also take note is that the highlight for scabies is the itching. But we know that we have what we call the clean man scabies. The big boys, the big madams who live in highbrow areas who don't itch, but they just come with that typical rash. And like Dr. Gold rightly said, if we trace those areas, we'll find out that they form a circle from the hand to the wrist to the elbow to the axilla to the nipple area down to around the umbilicus. They form, so that also guides us, particularly in those people that don't present with itching, in what we may also call the clean man scabies. So that may also be of help. Then for community involvement, there is also the approach of area spray of some of these scabicides for community involvement, maybe permethrin area spray, or you can give mass administration of ivermectin, as have been said. But it's important for us to note that, as has been said, and for emphasis purpose, scabies is here with us. And recent researches are trying to look at the use of PCR for research purpose for that. So for those who are interested in research, that's also another area. Then there are also the standard classification, the International Alliance for Scabies. There is the mild, moderate, and severe classification of scabies for those who are interested in research, because I've tried to look at our audience today. We have a large spectrum of people who are here. But by and large, when you see that patient with that Sweetie, Mobostop, and all of that, consider scabies, consider other differentials that have been mentioned. And when you try to treat once and it doesn't go, please refer. I think it's better, so that we do not, because beyond just the death, what if the skin of this patient goes irreparably affected, post-inflammatory hyperpigmented spot, black spots all around the place, particularly for a patient who has a background atopic dermatitis that tend to predispose them to some of all these things. So I think it's a good one that we have discussed scabies at length, and we should all go back and beam our searchlights and see how to push more on our policymakers to pay attention to scabies at the national level. Thank you.
Thank you, Dr. Ewo. Dr. Cole, I have some pictures I want to share. Dr. Abdullahi graciously sent them to me during the lecture. So, fantastic. The picture of Norwegian scabies that I showed was from the internet. Yeah. So this one is one of our patients that she's currently treating, and she just wanted to highlight Norwegian scabies. Just a moment. Yeah.
All right. Thank you. So I hope everyone online will be able to recognize scabies, please. There are a few take-home points. There are some particular areas of the skin that you find the scabies lesions, usually in between the fingers, in the groin area. It has a predilection for the penile shaft and, the penis in males. And, the warm areas like the armpit, the groin, the buttocks. You have a rash there that is usually worse at night. For some reason, the itching becomes worse in the night, although it can happen at any time of the day. But usually I ask my patients, is it worse at night? Where is the lesion located? Is any other person having this lesion? And then if you have all those, you want to think of scabies. Okay?
Can you
That's
see it?
very, very important. Yes, we can see the photo.
So that's a
Wow.
picture of a patient with Norwegian scabies that Dr. Abdullah is currently treating.
Wow.
So can you see that if you're just seeing this patient, you might just think this is chronic eczema.
Yes.
A high index of suspicion is very essential, and a very good history. From when did it start? How did it look like initially? What have you done? Will probably be able to lead you to the diagnosis. So that's the picture when she started treating, before she started treating, I beg your pardon. Then I'm going to show you a picture after she during the process of treating. So look at this. Look at this during the process of treating. So we can see that there's a huge difference. Can we see the next picture that I'm showing right now?
Yes, we can see it.
So we can see that there's a huge difference between when she started and right now. So Norwegian scabies can really, really become, that bad. And so imagine such lesions on the hands. Imagine it all over the skin. It can be that bad. And so in Norwegian scabies, you are using the cream, you are using the tablets, you are retreating, day 7, day 21, you might need to do day 28, depending on the response to treatment, because they have millions of mites on the skin. I want to check the chat box if there's any other question, but I don't think.
Yeah, I wanted to add one of the few times when we actually recommend the medicated soap is with scabies, and that's the use of Tetmosol.
Forgot.
Tetmosol, it contains 5% monosulfuram, so it's not just any medicated soap, but Tetmosol in particular that contains the active agent in Tetmosol is 5% monosulfuram, which is scabicidal, which can kill the scabies mite. So for that purpose, we do recommend medicated. Dermatologists, we don't like medicated soaps generally for everyday use. But as part of the management of scabies, we do recommend Tetmosol soap for a period of time, and particularly for people in places where there may be reservoirs like boarding school, like in the prison. So anytime we're going for the prison outreach, we do buy Tetmosol soap and distribute to people in prisons. And for boarding house, Tetmosol is also useful for the students if there is an outbreak of scabies. That's another thing that I wanted to add to that. Over to you, Dr. Cole.
Dr. Cole, somebody is telling you congratulations. Fahad Lawal says congratulations on your baby.
Oh,
we all
thank you
joined
so
to
much.
say congratulations.
Thank you very
Sorry,
much.
Dr. Cole, just 1 minute for the people. Thank you very much, Dr. Cole, for the presentation. For the people up here in the north, one of the problems we face for scabies are the Almajiri schools. We know how they are, congested, poor hygiene. So Almajiris, once you see Almajiris with itching, you should also have a high index of suspicion for that. And then again, permethrin, yes, but it's benzoate that we have available. Permethrin is not readily available. Ivermectin. In fact, this patient that is currently being projected, we had to have a gap because we're looking for ivermectin everywhere. We couldn't get it. One person was not able to help us with some reservoir that he had left from the COVID outbreak. So ivermectin too can be difficult to get. So what we have generally is the benzoate. And at times we really have to make extra efforts. This particular patient, the entire house is itching. The entire house is itching, but they're only concerned about this particular patient. So this is the only one that they brought. And the problem was no money to come and buy card, and see patient, and pay for their transportation and pay for everything. So I had to tell them that just come, just bring them. You don't have to buy cards. We'll just get the medicine. We are lucky MSF volunteered some medications and we use that to treat the entire house. And I want to highlight that there is some research, although not definitive, that there is a link between scabies and development of chronic kidney disease later, because of the super added bacterial infection that may come up with scabies. So please, let's not take it as only this is just an itch, this is just a rash. If it turns out to be true, then that is something that you'll be saving a whole lot of people from, because we see a lot of people, especially up north, young children, 19, 20, in their 20s, coming down with chronic kidney disease. We always say chronic kidney disease, secondary to CGN, we don't know where the CGN might be coming from. And there are research that shows that this might be one of the portal of the problems that the patients will later come up with chronic kidney disease. So please, let's be on the lookout. If you're not sure, just reach out. I've had people from this seminar reach out to me with cases. So if you're not sure, just reach out, please. If we don't know, we do know how to sort out the patient's problem. Thank you very much for coming. Thank you, Dr. Gold. Thank you, Dr. Gold.
Thank
Sorry.
you.
Sorry, can I just add a little? The benzyl benzoate. I think someone posted online that benzyl benzoate should not be confused with benzoyl peroxide. I think that's also another thing we should emphasize. When a doctor writes benzoyl peroxide for you for acne, don't go by benzyl benzoate. And for a pharmacist, please don't allow those who work for you to give benzyl benzoate or even the chemist.
Yeah,
they are
different.
Dr. Ayo, what we should just emphasize is that whatever medication one is prescribed, one should make sure they read it clearly before leaving the point of purchase. Because this thing just happened to me just last month. Somebody reached out to me that a doctor prescribed medications for acne and her face is just becoming worse. She doesn't know that, please, I should help her. I said, snap the medications you're using and send them. Lo and behold, she was applying benzyl benzoate to her face. You understand? So people, and she's educated, so people should really take the time to read the medication that they're being given, read it on the pack, and check your prescription before you leave the point of purchase. Don't assume that you're being given the correct thing, because after all, it's your health. So that's very important. Very important.
Yes, and people at the pharmacist as well shouldn't mix one for the other. So benzyl benzoate is very different from benzyl peroxide. Benzyl peroxide. So please, let's not make that error.
So the other thing again, I know some dermatologists would have had some experiences of patients with benzyl benzoate who use it very aggressively. You prescribe benzyl benzoate for specified period, and because the person is itching so much and wants quick results, begins to apply the thing more than is expected to, or even turns the thing to body cream. I'm sure dermatologists would have seen some cases of near burn that looks almost like burn, on that area of
it does cause
skin.
An irritant dermatitis. Very
serious burn. Yes. And in fact, there have been cases of seizures and even death as the result of some of these things. So I think we should also pay more attention to some of these things, especially when we have patients who need fast, sharp results. And instead of using it for 3 nights on, 3 nights off, the guy or the lady decides to use it 3 times in a day, for 2 or 3 weeks. No, that's not how it's supposed to be used. So, please, let's stick to prescription. See dermatologists, ask dermatologists if you're not clear. You are a health worker and you're not clear about what you need to do for treatment of scabies. Ask the nearest dermatologist and you'll be guided appropriately. Thank
you. Okay, thank you so much. Thank you, Dr. Oyo, for that. So on that note, I think if we're done with all the questions, I don't know if anyone has any other question and comment. We can call it a day. Thank you to everyone who has attended. And if anyone has any question or comment, you could just raise your hand and maybe we can allow you to talk. But if not, then we can close the session for the day. Okay, we have a few hands up. Let me start with Salamat KG. Salamat KG, I think you can speak now.
Okay. Good evening.
Good evening. How are you doing?
I'm fine, thank you. Thanks for the very enlightening lecture.
You're most welcome.
I was the one that asked about that patient that she has been having the itching for a long time, like a year now. And I was saying she was having swelling and all that. So I don't know if I can have the contact of any of the dermatologists that stay maybe Ilorin or Ibadan. So maybe I can send her down to consult the person.
Okay, great. Dr. Gold-Olufadi is in UCH. So maybe she can, if you want to share your email with her, Dr. Gold, we could do that, and then she can come into the clinic at UCH. Are you based in Ibadan?
No, the patient is in Kwara.
Okay, Laurie, we also have
I'm
Dr.
going to
Ilesomi.
send her Dr. Ilesomi's contact privately. I'm already sending her something privately.
Okay,
So
great.
that she can send a message to Dr. Ilesomi. Dr. Salama, Dr. Salama, you're a doctor, right?
Yes, ma'am.
Please, I would
Okay.
send you the contact of Dr. Ilesomi in Ilorin.
Yeah,
So you
she's in
can send
Ilorin,
her.
UITH.
It's closer. This is in Kwara.
Yes, yes.
So I'm also putting my own phone number. So privately to you, you'll see the message now. Okay.
Thank you very much. Thank you.
You're
All
welcome.
right.
That's
Thank
the first
you.
one is so you'll see it right now.
All right, great. Dr. Shokunbi is here. How are you, ma'am?
So good to see you again, Dr. Cole. So
And
good to see you. Thank you for allowing me and giving me the opportunity to speak. Thank you, Dr. Gold, yes, Dr. Gold-Olufadi and Dr. Oyo for putting this together. It's been quite a pleasant time and listening to the talk. I'm sorry I joined this discussion a little bit late, but I don't know if we mentioned the fact that although recently some schools are beginning to associate scabies, they're also listing scabies as an STI. I don't know if we mentioned that part, because at times you have this history of patients who come in with this chronic itch. And like Dr. Iwo rightly said, there are different clinical presentations. So you can have some form of clean man scabies. Sometimes you may not really see the classical lesions that you expect on the skin. But you need to ask beyond the household, because some patients may tell you, I live alone, there's nobody itching and I don't stay with any other person. You need to ask the history of their sexual contacts. Has there been anybody itching? Because sometimes that alone can just help you clinch the diagnosis. There's somebody around who is also itching. Most times we don't need too much talk. By the time you get the history, you see the rash, then there's a history of close contacts, whether in the household or otherwise, that are itching. So I just wanted to mention that scabies too has been listed as an STI by some authorities recently, just to add to the discussion. Thank you very much.
Thank you, Dr. Shokunbi. I know Dr. Gold mentioned that scabies can be sexually acquired, and to a large extent, we do have people getting scabies from their sexual contact or sexual partner. So yes, that is well noted, and that's something that people should also include in the history taking. When you have a patient with an itchy rash, and you want to think about that, because their sexual partner also needs to be treated, and that is very essential, because if you treat the person, I don't treat their sexual partners, they're going to have a recurrence of, the infestation. Thank you so much, Dr. Shokunbi. Thank you for joining in on the call.
Thank you. Sorry I joined late, missed that part. Thanks.
It's fine, no problem. So King Charles, I think King Charles, you wanted to speak as well.
Hello.
Hello,
Everyone.
good evening. Good evening,
Yeah,
sir.
good evening. Please, I must really commend the person that led the webinar. I mean, the speaker. It was really a very eye opener. A great eye opener in the area of management. So, like the last person that just talked said, I also joined a bit late. I was having a little difficulty connecting from where I am. I don't know if I'm audible enough.
Yes, we can hear you loud and clear, sir.
Okay, so I want to ask concerning the household, like the beddings and the rest of the household places that the person might eventually get contact. The time I actually logged in was when the doctor was explaining that that the lifespan of the, hello.
Yes, we can hear you.
What did you
Okay.
okay.
Okay, so the lifespan of the organism, outside the body doesn't take that long. Please, can I know exactly what's the frame? Assuming if the organism doesn't get into the skin, what's the time frame for it to die off, please? Hello?
Yes, sorry,
can you repeat that again, please?
Yes, it wasn't so clear.
Okay, I was saying, when I logged in was when the speaker was explaining that if the mites didn't get into the bloodstream of a person, that it will eventually die off, even if it's on the bedding or maybe on maybe inside the inanimate object. I want to know what is the time frame? Is there anything like time frame? Why I'm asking, it could also help in maybe advising maybe a group of persons or something like that on how to stay clear of the mites or something like that.
Okay, thank you so much. I think I understand your question now. So I mentioned that scabies is a mite. It cannot about the bloodstream part, so that I can elucidate further on that. It can't go into the blood. So scabies would remain a skin infection unless you have a complication of a secondary bacterial infection with glomerulonephritis and kidney failure. Okay, so it doesn't invade more than that layer that we call the stratum corneum, the upper layer of the skin. But because it has a life cycle, from the eggs to the larva to the nymph to the adult mites, and when you are transmitting from human to human, usually the pregnant mites. That's why you are able to propagate the infection. From that egg to the larva to that period takes about 4 to 6 weeks before they start excreting their feces, shedding part of their body onto the skin, causing the allergic reaction of the itching. So the incubation period, if you remember in medicine, when you talk about the incubation period refers to time of exposure to time of first symptom. So for scabies, the time of exposure to the mites to the time of first symptom is usually about 4 to 6 weeks. That is also why it is very important to treat both affected, and by affected, I mean that people that are already manifesting symptoms, and unaffected, which are people that are in close contact but are not manifesting any symptom, because they can be in the incubation period. If you treat only the person that is manifesting symptoms, when the other person that is incubating, when they start manifesting symptoms, you run the risk of running a recurrent vicious cycle of scabies infestation in that household. I hope I've answered your question. I hope I've answered the question.
Okay, I think I've taken off the speak, but I'd like to add the part that we spoke about earlier. You mentioned earlier that the mite cannot live off the skin for more than 72 hours. So I know he mentioned, is there a time frame? And that time frame is usually 72 hours. So if you are able to isolate all the patient's clothing and bedding for up to 72 hours, you can be rest assured that any mites that may be on it will die off within that time frame. So that also is, in a lecture I attended on scabies by an Indian professor, he mentioned that where you have challenges with water shortage and you want to get rid of, the mites on the fomites, you can just pack all the beddings and the clothing, put them in a black dustbin bag, tie it up for 3 days. And after 3 days, we are sure that all the mites would have died on those clothing and beddings. And that's one way to get rid of the beddings, or the room in which the person is sleeping can be abandoned or isolated for 3 days, and then you can go back into the room and you are sure that all the mites in the room would have died off. Dr. Belema, thank you so much for joining in. I saw you raising your hand. I guess you want to contribute. My chief from Port Harcourt.
Our chief is here.
Yeah.
Hello, Dr. Cole. Hello, Shaki.
Hello, Dr. Belema. Nice to have you.
Nice to have
Thank
you.
you. So I was about commenting on topical applications, but yes, the last comment you made is exactly what I tell patients I'm treating for scabies. So I tell them, when you go home, once you start treatment, every clothing you're wearing right now, your beddings, your towels, everything, tie it up in a bean bag and keep. And you can start washing as conveniently as you want. Because I know, I just rather telling them that the mites will not be able to survive away from the human body greater than 48 to 72 hours. So I tell them, this is exactly what I tell them. Pack all the clothes, everybody's clothes, just tie it up, everything you've used. And they keep on asking, what about the ones I haven't? What about the ones in my wardrobe? I say, that's fine. Just leave that. And I think it's also important to, you pointed out that you can as well abandon the room for that period of time, and you're sure that the mites would have died off. So I don't know if you mentioned about application of topical benzyl benzoate, that for infants and toddlers, if it's indicated or you find that you would like to use benzyl benzoate and you don't find permethrin, it's advised to do double dilution of the benzyl benzoate. So I tell patients, if you turn the benzyl benzoate into a capful, pour it in a bowl, take an equal amount of water and pour it in that bowl, mix it together and apply. For even smaller children, you can do almost 3 times dilution just to reduce the irritation that might occur. Then for permethrin, for those that are less than 15 kg that you might not be able to give ivermectin to, it's also advised that you can apply permethrin on the scalp, the forehead, and side of the face, because the child is not old enough to take ivermectin, which is more wholesome, systemic, will get to every part of the body. So the scalp, forehead, and side of face. I tell patients I see less than 2 years, their children about 2 years old, and of course not able to take ivermectin to do that. So it's something that can be done. So I have a family, and then you can get scabies again, especially if contacts are not properly traced and treated. So I treated a family, comfortable family, in January. The man, 2 kids, I had to do a scraping of the digital web spaces, and we cut the mites for him to be convinced that it was scabies. So treated the family, and I tried to contact trace as much as I could, and they all got treated. Lo and behold, this May, a few days ago, he comes back with same pruritus spots. Then they've been managing him for atopic dermatitis. And I didn't even know how to tell him this is scabies again. But I had to do it. This is scabies again. And he found it difficult. He now remembered that his mom also visited that previous time, and she wasn't treated. And she came in scratching in a recent visit where everybody, family had to come together for a wedding. So yes, if you don't contact trace, even sexual contacts, you're going to keep on running around in a circle, treating scabies over and over again, and it becomes a chronic problem. Thank you.
That's very true. Thank you so much, Chief. I really, really appreciate that. Very important. Treat contacts. Treat contacts. I'm currently treating another boy that I treated before, and maybe 1 or 2 people that came to the house at the time did not take treatment, and they come back again, and you have to start all over again. So very, very essential with scabies to treat contacts. Thank you very much, Chief, for that contribution. We have Halima Ada. I don't know if you can quickly share what you need to share so we can wrap up as quickly as possible. Is Halima there? I guess she's not there anymore. And the last,
Dr. Cole.
Yes, please.
Dr. Aino is also here. We have a lot of dermatologists in house today. Thank you, Dr. Aino. She just
Okay,
left a
thank you.
comment.
Yeah, I think I saw her comment on the chat box and the Q&A box. Dr. Aino, thank you very much for joining in. We have dermatologists all over the country. So if you need details of the closest dermatology center facility near you, please contact us. You can send an email and we can send a list of dermatologists that you may want to contact if you have any patients that you'd like to refer or challenging cases that you'd like to discuss. So Fahad Lawal, I think you'll be the last person that will, if you are still there, if you'd like to share anything or ask any question.
All right. Good evening, Ma.
Good evening. Good evening.
Congratulations once again.
Thank you very much.
Okay. Ma, I would like to ask, like, personally as a child, like, I want to ask if the scabies has this spontaneous remission. I could remember when we had this scabies, what we were sent, because it was probably infected, it was oozing force. So we were just sent to do benzathine penicillin, procaine penicillin injection then. And I don't remember us being applied any topical cream or anything, and somehow it disappeared. Though it stays, I could remember it stays for a very long time before they wash our linens and format in the house. But I don't remember us using any specific scabicidal agent. So is there any literature that support that it can spontaneously remit? Though I know we were treated for the bacterial infection, then actively. Then second is the issue of being it neglected tropical disease.
Hello? Sorry, you're no longer audible, Mr. Fahad or Dr. Fahad. Hello? Something must have gone wrong with your audio. Maybe when if you can rectify that before, but the first part of your
I'm not sure. Dr. Cole, did you hear everything he asked?
oh, sorry, I think it was my network that was fluctuating. I just got the first part, but I didn't get
Dr. Ewo, I don't know if you heard, because I don't know why. I just couldn't hear him very well.
Okay, Mark,
Yeah.
can you hear me now?
Yes, yes.
Okay, you may wish to come again.
Okay. What I said in summary is the first one, whether there is any possibility for scabies to remit spontaneously. As a childhood experience, we were never given any specific creams, the ones that has been listed during the lectures. However, it was secondarily infected. I remember the force coming out of the lesions and the rest, and we are actively treated with procaine penicillin injections then. So whether it can remit spontaneously, and it disappeared, though it followed a protracted time over 2-3 months before it disappeared. It was shipped to the home by the boarding house students. Then the second one is being it neglected tropical disease, and there is this campaign roadmap NTD 2023. Whether apart from ivermectin, there is any other effort that WHO is doing in curtailing the scabies now to address it. It's one of the most easily treatable NTD that may not require a lot of resources, so to say, in controlling it.
Yes, they are very correct. So with the first part, it's possible that it may not have been scabies, because scabies is quite persistent if not properly treated. Or possibly they had used something that was able to curtail it without knowing. I know some people that never took any scabicidal, but I think maybe they used Tetmosol soap, and that eventually, gradually over time, was able to wipe out the scabies mite. But there are two possibilities. One possibility was that it wasn't scabies, it may have been something else. Another possibility is that maybe you inadvertently used something that was scabicidal and eventually was able to control the infestation. So yes, with regards to the roadmap, the 2023 roadmap for NTDs, I know Dr. Oiwan mentioned this earlier. Scabies is probably the most common skin NTD that we experience in Nigeria, but there isn't much of a plan yet for scabies, and it's a low-hanging fruit, so to speak. So I know that there are some, how will I put it now? There is the option of mass drug administration of ivermectin when it comes to scabies. And we are hoping that we can have more of that being handled by the ministries of health, the NTD control program in communities where there are high prevalence of scabies. There are reservoir communities as well, places like we've mentioned, like prison, school, some underserved areas where you have very high prevalence of scabies, and if you have MDA, mass drug administration, in these communities, you can reduce the prevalence of scabies across board and eliminate reservoir communities of scabies in in Nigeria and the community. So it would be nice for that to be spearheaded by the NTD control program, aided by the WHO. And also, as much as possible, when we have community outreaches, I always tell people, you cannot go to a community outreach in Nigeria, to a rural community, without ivermectin. As much as possible, ivermectin should be on the essential drug list. That should be one of the drugs that are always, included in the list of medications. If you are going for a rural community outreach, if you're going for a prison outreach, there's no way that you will not encounter, cases of scabies in such communities, and it would be nice for you to be able to administer drugs to treat those cases. So that's one thing that we should also have in mind. As part of this project, leading on to that, we, at the end of the webinar, we hope to have physical community outreaches in various communities where we'll go out into a particular community and try to check and treat skin NTDs in those communities based on what we have learned during this webinar, and report the cases that we find. So that will be coming up shortly, probably sometime in July, when we are done with the all the webinars sessions that we have planned out for this serum, for this training. So our time is fast spent, and I think we need to wrap up for today. Thank you, everyone. Thank you, Dr. Gold-Olufadi, for the fantastic lecture. Thank you very much for everyone who has contributed to the lecture today, Dr. Belema Abe, Dr. Shokumbi, and all the other participants who shared from their knowledge, their wealth of experience, and asked questions and contributions. So we'll meet again in another week or two for the next session. You can catch up with all your previous lectures on YouTube, and you can also put questions there if you have any further questions or comments. Thank you very much, everyone, for joining in today. We call it a day, and have a superb week ahead. Thank you so much.
Thank you very much, Ma. Lymphatic filariasis is still missing. We can't find it on YouTube.
It's there. Oh, it's there. It's there.
I can trouble getting it.
If you send me a link, if you send me an email, I'll send you a link to the lymphatic filariasis, but it's definitely there. I still checked, during the course of this webinar, I found it there. So
let me drop my email.
Yes, so just
drop my email now.
All right. Okay. All right then. Take care and have a blessed week.
Take care, everyone. Well done, Dr. Cole. Well done, Dr. Gold. Bye.
Bye-bye. Bye-bye.
Fine. I've posted the email.
Okay.
Thank you very much, Dr. Gold. Thank you, Dr. Cole. Congratulations once more. See you soon. Bye.
All right. Yeah. Bye-bye. Okay.